Welcome to AS Pharma. In this video, we will learn about the anticholinergic drugs. And as the name indicates, these are the drugs that antagonizes the effect of parasympathomimetic nervous system, or these are the drugs that blocks the effect of parasympathetic autonomic discharge. Hence, all these terminologies, anticholinergic drugs, parasympatholytic drugs, and cholinergic drugs, they are used interchangeably for the drugs that antagonizes the effect of parasympathetic nervous system. Cholinergic antagonist or anticholinergic drugs, they are divided into two main subclasses: antimuscarinic and antinicotinic. As we know that the parasympathetic nervous system, it has two receptors, nicotinic and muscarinic. So based on these kinds of receptors, the anticholinergic drugs, they are divided into two main branches. The drugs that inhibits the effect of muscarinic receptors are termed as antimuscarinic drugs, and the drugs that inhibit the effect of nicotinic receptors are termed as antinicotinic drugs. This is a very simple illustration of a synaptic junction in which this right here, the black line, it indicates a nerve terminal. This area is the junction right here. And these are the receptors. These are the cholinereceptors. Now the production of acetylcholine, it happens inside the nerve terminal. Here we have acetyl coenzyme A and a molecule called choline. Both of these, they combine to form the acetylcholine, which is the neurotransmitter of the parasympathetic nervous system. This acetylcholine is transported into this vesicle, and from this vesicle it goes outside the cell by fusing into the membrane right here. So this vesicle, it fuses with the membrane and is then released into this junction. Now in this junction, acetylcholinesterase enzymes are also present, and cholinergic receptors are also present. So these are the cholinergic receptors that we have already discussed. That we have two cholinergic receptors, nicotinic and muscarinic. This acetylcholine, it binds with these receptors and produces the effects of parasympathetic nervous system. However, the drugs which are anticholinergic, they blocks these receptors, they bind and they block the effects of these receptors, and hence they are known as anticholinergic drugs. So all the effects that are produced by the parasympathetic nervous system, all the effects are reversed when any anticholinergic drug is introduced into the body. So the antimuscarinic drugs, they are divided into two main classes: the tertiary amines and the quaternary amines. In the tertiary amines, we have atropine, scopolamine, pyrazine, dicyclomine, benztropine, and tropicamide. And in the quaternary amines, we have propanthyline, glycopyrrolate, tiotropium, ipratropium. So all these drugs, they have different applications. The atropine is the prototype of these drugs, and many similar plant alkaloids are also known. And there have been hundreds of synthetic antimuscarinic compounds that have been prepared in the history. While only these compounds are available in the market, some of these are available and some are not. So we have atropine. Atropine is a drug that is widely used in clinical practice in order to treat the bradycardia. Scopolamine is used in motion sickness, and like this benztropine, it has application in the Parkinson disease. So likewise, from the quaternary amines, we have tiotropium and ipratropium, and both these drugs are very important in the management of asthma. We have glycopyrrolate, which is used in the pre-surgical procedures, where this drug is used to reduce the secretions inside the gastrointestinal tract. So all these drugs, they have different clinical effects and are used to treat various conditions. In the nicotinic receptors, antinicotinic, we have two kinds of nicotinic receptors. There are two subclasses, NN, which are the neuronal nicotinic receptors. They are present in the neurons. And we have NM, which are present in the muscle, in the neuromuscular junction. So these are the two subclasses of the nicotinic receptors. So the classification of anti-nicotinic drug is also based on the kind of receptor. So we have an N blocker and we have an M blocker. Both these are classified into depolarizing and non-depolarizing. So in the depolarizing, we have nicotine, we have lobuline and carbamylcholine. And in the non-depolarizing, we have trimetaphone and megamylamine, hexamethonium. Whereas this class is very important, as these drugs are used as neuromuscular blockers in the surgeries. So we use these drugs very widely in the setting of surgeries when we need neuromuscular blockade or when we want to paralyze the patient. So we have in depolarizing, we have succinylcholine, and in non-depolarizing, we have all these curium class. We have atracurium, cisatracurium, pancuronium, vicuronium. All these drugs are used as a paralyzing agents in the setting of surgery. When we are preparing the patient for surgery, we have to paralyze them along with the sedation. So these drugs, they have important role in the setting of surgery. So these are the drugs that are anti-nicotinic. They bind with the nicotinic receptors and they block the effect of nicotinic parasympathetic nervous system. So let's discuss the pharmacokinetics of anti-muscarinic drugs and anti-nicotinic drugs. So these alkaloids, the natural alkaloids and tertiary anti-muscarinic drugs, they are well absorbed from the gut. And the conjunctival membrane as well. When they are applied in a suitable vehicle, some of the drugs, they are absorbed across the skin as well. For example, we have scopolamine. Scopolamine is a tertiary amine that belongs to the antimuscarinic group, and it is available as a transdermal patch, and it gets absorbed from the skin and is used in the treatment of motion sickness. So they have pretty good absorption. As far as the distribution is concerned, atropine and other tertiary agents, they are widely distributed in the body. Their levels in the CNS are achieved after approximately 30 minutes. They crosses the blood-brain barrier, and this distribution across the CNS, it can limit the dose tolerated when the drug is taken for its peripheral effects. Scopolamine is very rapidly and fully distributed into the CNS, and it has greater effects than most other antimuscarinic drugs. However, the quaternary derivatives are poorly taken up in the brain and therefore are relatively free at low doses of CNS effects. So we discussed two kinds, the quaternary amines and the tertiary amines. So these tertiary amines, they have good CNS penetration, and this CNS presentation, it limits their use for its peripheral effects, whereas the quaternary amines, they do not have good CNS penetration, poor CNS penetration. So they do not have the side effects that are associated with the CNS penetration. So we can use these drugs, propanthyline, glycopyrrolate, tiotropium, and ipratropium without the concern of any CNS toxicity. After administration, the elimination of atropine from blood, it occurs in two phases. The rapid phase is around 2 hours and the slow phase is approximately 13 hours. So 50% of the drug, it is excreted in the urine as the unchanged drug, and the metabolism is hepatic. Two main processes occurs during the metabolism. One is hydrolysis and the other is conjugation. After these reactions, the drugs are excreted by the kidneys into the urine. So this is how it gets out of the body. In order to recap, it is absorbed well from the gut and from the skin as well. It has a high distribution. All these drugs, tertiary amines, they are readily distributed into the brain as well. They crosses the blood-brain barrier, whereas the quaternary amines, right here, they do not have very good CNS penetration. The distribution, they are widely distributed in the body. Metabolism is hepatic in the liver, and the excretion is in the urine by the aid of. We'll discuss the organ system effects of antimuscarinic drugs now. In the central nervous system, atropine has a minimal CNS stimulant effect. It will stimulate the CNS, but this effect is very minimal. It is not clinically significant. However, especially the parasympathetic medullary centers, they produces a longer lasting sedative effect on the brain. So initially it has a CNS stimulant effect, but after the antimuscarinic drugs, it produces prolonged sedation. And this is true for the drugs that crosses the blood-brain barrier, which are tertiary amines. And scopolamine, it also has marked central effects, and it produces drowsiness when it is given in recommended doses, and also amnesia in sensitive patients. The tremors of Parkinson's disease is reduced by centrally acting anti-muscarinic drugs, for example, atropine. However, now atropine is not used for the treatment of Parkinson's disease because of its other effects, and the mainstay of Parkinson is levodopa. However, in the past, benztropine was used for the treatment of Parkinson's disease. So we have role in Parkinson's disease, and we have role in motion sickness. In the motion sickness, we use the drug scopolamine. Scopolamine will produce a bit of sedation and amnesia as well. Next organ after the brain is eye. The pupillary constrictor muscles, they depends on muscarinic chorioreceptor activation. And if we recall, we know that the muscarinic receptors, the activation of muscarinic receptor causes miosis in the eye. That miosis means it reduces the size of the pupil. So when we block the effect of muscarinic receptor, the effect that is produced is mydriasis. So this effect is very important when we are doing any ophthalmoscopic examination. And along with mydriasis, there is also cycloplegia, which is the paralysis of the ciliary muscle. Cycloplegia results in the loss of ability to accommodate, and the fully atropinized eye cannot focus for near vision. So both these effects, mydriasis and cycloplegia, they have a role in ophthalmoscopic examination. However, they are potentially hazardous, and acute glaucoma may be induced in patients with a narrow anterior chamber angle. So glaucoma can be induced. Also, these drugs are contraindicated in the state of previous glaucoma. Third organ is the heart after eye. So in the heart, we have SA node right here. This is the SA node, and from this SA node, the impulse is transmitted into the AV node right here, and from there, then impulse is generated in this way. So we have muscarinic receptors here in the node and in the muscles of the heart. So what actually happens is that when the parasympathetic nervous system is activated, it causes a negative chronotropic and negative ionotropic effect. So when we give an antimuscarinic drug, the effect on heart are positive ionotropy. Positive ionotropy means the contraction of heart is increased, and positive chronotropy means rate of heart is increased. So we have both increase in rate, and we have an increase in the force of contraction of the heart. So we can see tachycardia in patients in which we give antimuscarinic drugs. Tachycardia is a high heart rate, the heart rate that is greater than 100 beats per minute. We have normal heart rate that varies between 60 to 100 beats per minute. This is a normal rhythm, and this is tachycardic, in which the heart rate is greater than 100 beats per minute. So whenever we give any drug for any antimuscarinic drug, we can anticipate an increase in the heart rate and increase in the force of contraction. So this effect is utilized in the setting of bradycardia. So we have atropine. Atropine is used in the treatment of bradycardia. Any symptomatic bradycardia in which the heart rate is less than 60, in those conditions we use atropine. The SA node is very sensitive to muscarinic receptor blockade, and moderate to high therapeutic doses of atropine, they can cause tachycardia in the innervated and spontaneously beating heart by the blockade of vagal slowing. And the same mechanism it operates in the AV node. In the presence of high vagal tone, atropine can significantly reduce the PR interval of the ACG by blocking the muscarinic receptors in the AV node. AV node, we have AV node here and SA node is here. So most blood vessels, except in those in thoracic and abdominal viscera, they receive no direct innervation from the parasympathetic system. Atropine can also block the vasodilation in these vessels. Next is the respiratory system. And in this diagram, we can see that we have a normal airway, and in there we have an asthmatic airway in which the muscles are, the walls are bit inflamed and they are thickened, and the excess mucus is also secreted at the smooth muscles. They are also very tightened. So in the airway, there are smooth muscles which have a parasympathetic innervation, and there are glands which have parasympathetic innervation. So we have two areas to cover. One is the smooth muscles, which are responsible for the contraction and the dilation of the bronchi, and we have glands which are responsible for the secretion. Right? So both smooth muscles and secretory glands of the airway, they receive vagal innervation and they contain muscarinic receptors. So even in normal individuals, administration of atropine can causes bronchodilation and it reduces the secretion. So this effect is very significant in patients with airway diseases. However, the anti-muscarinic drugs are not useful as the beta agonist for the treatment of asthma. However, we use anti-muscarinic drugs in the setting of asthma, and we have two drugs, tiotropium and ipratropium. Both these drugs are widely used as inhalers in the treatment of asthma. Moving on, we have gastrointestinal tract. The blockade of muscarinic receptors has dramatic effects on the motility and some of the secretory functions of the gut. So just like the respiratory tract, we have GIT. In the GIT, we have two major areas where we have parasympathetic innervation. One is the smooth muscles of the walls and the sphincters, and the other is the glands, the secretory glands. So what happens is that when parasympathetic nervous system is activated, the walls are contracted and the sphincters are usually relaxed. So this happens when the parasympathetic activation occurs. Whereas when we block this parasympathetic innervation, we reverses the effect. All these effects are reversed. So the walls, they are relaxed, and the sphincters, they are usually contracted. Anti-muscarinic drugs, they have marked effects on the salivary secretion, and dry mouth occurs frequently in patients that are taking anti-muscarinic drugs. This is also an adverse effect that is associated with the parasympathetic anticholinergic drugs. So the gastrointestinal smooth muscle motility is affected from the stomach to the colon, and we have a preparation of atropine with diphenoxylate. So both these, this combination, it is used for the treatment of diarrhea. Diarrhea is a situation in which the gastric motility is increased. So both this combination is used to treat the diarrhea. Also, we have a drug glycopyrrolate, which is given to reduce the secretions of the GIT as well as the respiratory tract. So they are now the anti-muscarinic drugs. They are not very common and they are very rarely used for the peptic ulcer disease. However, they can provide some relief in the treatment of traveler's diarrhea and other self-limiting situations of increased motility. So only this combination is available in the market for the treatment of diarrhea. In the urinary tract, we have smooth muscles. two kinds of smooth muscles. There are muscles that are present in the walls, and there are muscles that are present in the sphincter. We have detrusor in the wall and we have triazone in the sphincter. So what usually happens is that when parasympathetic nervous system is activated, the walls are usually contracted and the sphincters are usually relaxed. And when we give an anticholinergic drug, an opposite effect is seen. The walls are relaxed and the sphincter is contracted. So atropine and other antimuscarinic drugs, they have been used to provide symptomatic relief in the treatment of urinary urgency. However, the urinary urgency that is associated with the minor inflammatory bladder disorders. In the human urinary bladder, we have M2 and M3 receptors, and they are expressed predominantly with the M3 subtype mediating direct activation of the contraction. So for this purpose, we use the drug oxybutynin. It is still available in the market. It has a very major role in the setting of urinary urgency. We have this drug oxybutynin. We also have a drug which is called as trospium. So trospium is a non-selective antagonist. It has been approved and it has a comparable efficacy and side effects as compared to oxybutynin. There are also the drugs dorifenacin and solifenacin. So both these drugs, they are recently approved and they have a greater selectivity for the M3 receptors as compared to oxybutynin or trospium, and they have the advantage of once daily dosing because they have a longer half-life. So we give in once daily dosing both of these drugs. We also have a class in the antimuscarinic group that is tolterodine and fesoterodine. Both these drugs, they are M3 selective. They are selective for the muscarinic 3 receptors, and they are available for use in adults with the urinary incontinence. They have many qualities of terifenacin and solifenacin, and are also available in extended release tablets. And the convenience of these drugs, because they can be used as a once daily dosing regime. So we also have a TCA, which is imipramine. It also has stronger antimuscarinic drugs, and it has been used to reduce the incontinence in institutionalized elderly patients. This drug is a tricyclic antidepressant, but due to its antimuscarinic activity, it is used for the treatment of urinary incontinence. We also have another drug, propivirine, which is a newer antimuscarinic drug, and it is also approved for the use of urinary incontinence. The adverse effects of anticholinergic drugs are a bit explained in this picture. They are the direct extension of their therapeutic effects. In the eye, we can see mydriasis and non-reactiveness to light, as the patients, they also, along with the mydriasis, they have cycloplegia, and there is an inability of the ciliary muscles to contract. Cycloplegia is basically the paralysis of the ciliary muscles. So mydriasis, it is a very common side effect that is seen with the anticholinergic poisoning or anticholinergic drug as part of the adverse effect profile. Because they enter the CNS, the patient may appear confused or agitated or experience delirium. There could be flushing of the vessels, dry mouth, tachycardia, arrhythmias. We can see diminished bowel sounds because of constipation, paralytic ileus, because the gut motility is reduced. and urinary retention is common, warm and dry skin. So all these effects, they are the adverse effects of the anticholinergic drugs. However, we use these drugs for clinical purposes as well. So this was all about the anticholinergic drugs.